respected chairpersons, senior members, and my dear friends. At the outset, I sincerely thank Dr. Mohan and his team for the invite and to be associated with this mega event every year. Thank you. My topic today is classification and diagnosis of diabetes. I will take you through a little bit of introduction and touch upon the history and evolution of classification, the myriad ways of classification, the need for newer classification, the future, and the diagnostic criteria and what are the limitations of it at the moment, and what's new in diagnosis of diabetes, and end up with a summary. Classification of any disease is to identify and understand the specific type of the disease and offer specific therapy. And diabetes, as you know, is a heterogeneous disease and commonly called by Professor Sam G.P. Moses as hodgepodge disease with a wide spectrum of varieties. And moreover, these may be varying even in an individual who would move out from one area to the other. With newer observations, diagnostic skills, and newer classification is to be born. And I would be presenting in an unconventional discussion on the classification and diagnosis, and because most of us are well versed with the charts which we see or the tables which we see in all the textbooks about the various types. Coming to the history and evolution of diabetes classification, it started in 1965 by WHO based on the age. It was called as juvenile diabetes and diabetes. Later on in 1980, after the NDDG, they divided into IDDM or insulin-dependent diabetes mellitus and non-insulin dependent mellitus, and they also called it as type 1, the Roman letter 1 and Roman letter 2 for respectively for these diseases. Later on in 1985, the study group report on WHO, they kept IDDM and NIDDM, but added on MRDM, the malnutrition-related diabetes, and IGT and GDM. And a little later, 1999, there was modification, and 2021, the ADA said, type 1, now it is Arabic number 1, Arabic number 2. Special types like MODI, and diseases in the exocrine pancreas, drugs and chemicals induce diabetes, as well as GDM. These are main multiple ways of classification. The historic classification, the immunopathological classification of type 1, the pathogenesis-based classification for type 1, the phenotype-driven subclassification strategies, the genetic subclassification beyond monogenic diabetes, clinical classification of diabetes, the risk stratification-based classification of type 2, and clustering of diabetes in Indian population. This is the oldest one wherein they had type 1 and type 2 together, and there was an overlap which was also called as 1.5, type 1.5, 1.5, which included a condition called LADA and ketosis-prone diabetes. They said this particular overlap causes these two, but later on, when they identified the gestational diabetes, monogenic diabetes, as well as the others, everything started overlapping, and thereby their issue is something to same, at the same time little different. So the pathological aspect, the clinical aspect were overlapping. Next, we heard a lot of things about the immunological assault. In type 1, the beta cells act as an antigen-presenting cell, thereby getting the assault of inflammatory substances like antibodies, T lymphocytes, cytotoxic T cell, killer cell, everything. And this produces a autoimmune beta cell damage. Whereas in type 2, starting from the adipose tissue, liver fat, at the same time, the gut microbiota, which through the monocytes and macrophages produce cytokines, inflammatory cytokines, which again cause damage to the beta cell, producing apoptosis, de-differentiation from beta cell to null cell, and finally the beta cell mass is dwindling down. So inflammation happens in both type 1 and type 2, but in a different sector. Having understood that there is an inflammation, anti-inflammatory drugs was used in the therapeutic armamentarium. But this did not prevent or retard the progression or cure or help in the management of type 1 diabetes. So this was left alone. Then we entered into an immunopathological classification of type 1 diabetes, wherein type 1 T1D, E1, E2, and LADA endotype were discussed. Here, the E1 is something occurring in classical type 1, which we see, younger age group, aggressive autoimmunity, patient becomes perhaps resistant to you with ketosis. The E2 is older onset, little later in the age group, and the autoimmunity is gradual or chronic. Then we had the LADA, which started over the management of diabetes with OHA, then progressed suddenly with a short spell to immunological status requiring insulin. And all these things also had various stages, stage 0, 1, 2, and 3. In stage 0, the only thing we had is a genetic predisposition. Antibodies were negative, and also beta cells were normal. So it was also called as autoimmunity A negative and beta positive. Then in stage 1 and stage 2, gradually the antibodies started developing. So A plus and beta was normal. And stage 3, at the end of the spectrum, you had autoantibodies to 1 or 2, A plus, and beta cell was also gone, so beta minus. So this appeared to be the end of it, but later came the HLA. So HLA were classified into susceptible HLA and also protective HLA. But this also did not fully cover up the type 1 diabetes, because there were cases with a protective HLA with diabetes. That could be a genetic problem or specific selected gene polymorphism in type 1 diabetes, just like what we tell for MODY or type 2. So these were mostly an inflammatory genes, but the problem is HLA, yes, and beyond that it was a genetic polymorphism. The third is pathogenesis-based classification, wherein this was an old concept that the genetic composition loads the gun and the environmental factor triggers it. But in the 21st century, there has been a change wherein the genetic composition or contribution is less and the environmental assault is little more. And then the phenotypic-driven subclassification strategy was started. They had 5 clinical subtypes of type 2 at the time of diagnosis, and it was an Andes study with 6 variables like GAD65 antibody, age at onset, BMI, A1C, HOMA2B, HOMA2IR were considered, and this was even used as a classification by Leaf Group and colleagues. And this phenotypic diabetic subtypes goes on like that. Severe autoimmune diabetes, SAID, with GAD positive, low HOMA2B, lower BMI, higher risk of baseline neuropathy. The severe insulin deficient diabetes, SIDD, with low HOMA2B, lower BMI, higher risk of retinopathy and neuropathy. So this gradually, from a leanness, you go on to the obesity. In the severe insulin-resistant diabetes, a high HOMA2B, high HOMA2IR with hyperinsulinemia, high BMI, late onset, higher risk of chronic kidney disease. Mild obesity-related diabetes, high BMI, early onset, less progressive disease. And the MARD, or mild age-related diabetes, late onset, less progressive. So I always used to say and feel that if God appears in our dream and says, Asirvatham, you should get a diabetes, what diabetes should I choose? I always feel that I should choose a MARD, because that is probably the late onset, less progressive. So genetic subclassification beyond monogenic diabetes. So even for type 2 diabetes, today genes have been identified for the decreased pancreatic beta cell function, as well as increased insulin resistance. It could be an obese-related or even lipoatrophic insulin resistance. All these things were not helpful to the clinician. So clinical classification of diabetes was born. So not very different from the usual one. In type 1 diabetes, you have a idiopathic type 1 diabetes, which is probably genetic or beta cell damage due to a direct virus invasion like even COVID. And fulminant type 1 diabetes is usually a severe immunological assault with a recurring ketoacidosis and the classical presentation which we see. Type 2 we have already discussed, and gestational diabetes already is there. And one more newer form is called hybrid form. Just like hybrid cars which we have, battery as well as the fuel petrol, we have something of contribution from type 1 and type 2. And that makes a LADA change its name to slowly evolving immune-mediated diabetes. And the ketone-prone diabetes has also been called as ketone-prone type 2 diabetes. So these are the newer things. Rest of the things are quite old. And this is a risk stratification-based classification of type 2 diabetes, which was published by Mohan et al. It has got so many risk factors. For example, low birth weight, thin fat individual, Indian. So this is something due to with Barker's hypothesis, or probably even a low muscle mass, the sarcopenic diabetes. So these risk factors may be one or more, and if you stratify the patients of that sort, treatment could be focused on that particular risk factor in preventing and treating these diabetes. And clustering of diabetes was also done in the Asian population by Mohan et al. And they identified SIDD, or the severe insulin deficient diabetes, and insulin resistant obese diabetes, and the combination of both the combined insulin resistant and deficient diabetes and the age-related MARD. So all these things indicate insulinopenia on that side and in hyperinsulinemia or reasonable amount of preservation of insulin as you go down the right side. I still remember my professor, Dr. Kannan, who did a study when I was there as a student. He plotted out C-peptide and identified that lean patients have low insulin and obese patients have hyperinsulinemia. And this we published in 1990. But beyond that, we couldn't do much of the research work, and then it went on like that. And today we have really learned and affirmed that particular old result. The clusters also help us to say which cluster has more complication. Particularly the SIDD, wherein there is insulinopenia, the retinopathy is more common, and nephropathy is almost common in all categories of the clusters, and the hazard ratio is given below. So now there has been a need for newer classification because of the heterogeneity of diabetes, because we thought type 1 and type 2, that is over. But today, so many types have developed because of genetic, environmental factors, and our clinical classification and presentation. Traditional binary classification, which I told you, cannot account for this particular entity. And we have a lot of information regarding genetic and metabolic factors. So that to accommodate that, we'll have to have newer classification. And to guide more targeted or effective tailored treatment strategies, we need this. Now, what will be the future diabetes classification? We have already discussed about the clusters, and this cluster tells you that, anyhow, the clusters are not permanent. It's almost like living in a rented house. So today, one group of patients are living in this cluster, the other cluster, so on 5 clusters. They interchange, they move out of it. So where do we position them? It's a big problem. What have we achieved by grouping them into a particular group? Now we move on to the present status, which you see on the right side, wherein they've all moved out from these houses or the clusters. And you can also see them in a unique color on the other side, on the left side. And here there's a mix and match of various colors. What it really depicts is there has been some sharing of factors from this cluster to that cluster, so that may not be the ultimate classification. So what is to be done now? So multiple trait regression modeling for outcome has to be developed. By that we mean, for a particular drug, these are the factors that would help a patient to improve on this particular drug. Same way, the outcome of complications could also be grouped into a multi-trait regression modeling, so that you will know that these patients will respond to this particular drug, and these patients will develop this complication or not develop this complication, provided they don't cross the decision point. So this is a newer concept which is probably going to come up. This is a very interesting Chinese study, the exploratory study on classification of diabetes through a combined random forest classifier. So these are the various risk factors which were identified in already known diabetic patient, and they are trying to reclassify them depending upon the risk factors. You see here, the main risk factors are hypertension, heart rate, region, BMI, hyperlipidemia, and age. The first 6 are more correlating with the problems. And another interesting thing would be fresh fruits also having a little more increased risk, whereas vegetables are having on the other side of the null of line of null. So vegetables are healthy, fruits may not be that much healthy beyond 1. So this is a factor which they have identified. And how do this particular entity correlate? It is something like that, what Mohan has already had in the scoring system. You give more importance to a factor which is dominating or which is responsible for causation of the disease. So that is how this has been identified in the Chinese population. Then we have one more entity called correlation matrix. It's also known as a heat map, wherein it correlates the coefficients between the two variables like central obesity and BMI, wherein you have a very high correlation. And if it is going to close to 1, it indicates a strong positive correlation. The white color, which I'll show you right now, indicates a strongest correlation, and the maroon color indicates a least correlation. It's almost like a heat map for the renal status, correlating eGFR and the microalbuminuria. So when you compare this particular entity, a combination of BMI and central obesity would come to the white color, so which is almost on the top of the risk factor. Whereas vegetable eating plus some other less risk would be a little more safer. So this is going to be the future. Probably we'll add on more risk factors, we'll quantify them a little better, and we'll mark out or chart out where exactly our position is. Moving on to the diagnostic criteria, not much of change. 100, 126 at the fasted state. You have the normal IFG and diabetes. And in OGTT, the magic numbers are 140 and 200. The normal IGT or prediabetes and diabetes. And A1C 5.7 and 6.5. Normal, prediabetes and diabetes. And a random blood glucose of 200 with osmotic symptoms are also acceptable. Limitations of the current diagnostic tool are diabetes is a progressive disease and does not adhere to one particular disease, one particular status. It moves this way or that way. So it is absolutely, the thresholds are at a given point, beyond which, including glycated hemoglobin, they move and always it's a continuous and dynamic process. The postprandial 1 hour value correlates closely with subclinical inflammation, target organ damage, increasing cardiovascular and microvascular complications and death risk, and as evidenced by the various higher risks over the 1 hour post-OGTT value. But we don't have a standardized norm for that particular entity. What are the alternative diagnostic choices? Glycated albumin, the younger brother of hemoglobin A1C, specific, at the same time sensitivity is good, and not much of alteration because of the hemoglobin changes in anemia, CKD, and it's a good biomarker. Continuous glucose monitoring is almost like a continuous video of every one of us. So that will be giving a video-like picture of our glycemic control from the day to almost for a 2 weeks period. So that is also going to be a good diagnostic aid in future. And glycated serum protein also of a similar manner is going to give you long-term entity. What's new in diagnosis of diabetes? This is really thrilling. The diabetes theranostic, therapy plus diagnostics, are based on biosensing technology. The ring that you see on the right half of the panel, upper half denotes the diagnosis and the lower half discusses with the therapeutics. And it takes up entities which are invasive and non-invasive. And in invasive is blood glucose, microRNA, body fluid, or even the volatile organic compounds. And metabolic markers like branched chain amino acids, organic acids, lipids, and molecular markers like microRNA, autoantibody, and non-invasive or minimally invasive electrochemical sensor platform. By all taking up all these factors, a diagnosis is made, and the treatment also is offered to you. The treatment may be this medication, or probably an insulin, or even up to a level of insulin regimen. So this is about the future. So dear friends, to summarize what I have been alluding to for the last 15-20 minutes is better understanding of diabetes urges to improve current diagnostic and classification of diabetes. And this would enhance early and accurate diagnosis as well as precise treatment, which is the the important thing in this particular era. Newer pathophysiological mechanisms contributing to hyperglycemia is increasing, and this paves the way for modification of the existing criteria as well as diagnostic tool as well as for therapy. However, currently there is a lack of evidence to show that newer diagnostic and classification strategies improve the diabetes outcome. Ultimately, the proof of the pudding is eating. If you're just talking about this, that, everything and not doing anything, I feel that we are little less efficient as far as the outcome is concerned. And therefore, what we'll have to do is wait for the prospective data. So thank you very much for your patient listening and the opportunity given. Thank you.